Welcome to today's webinar, Efficient, Intelligent, and Personalized Remote Patient Monitoring for COPD, How to Ensure that your patients get the right care at the right time. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Heather Marcus, Vapotherm Access VP of Customer Experience. She will be joined by Dr. Michael Jacobs, VP Research Development at Temple University, and Dr. Mark Boomer, pulmonologist at Respiracare. I will now turn the microphone over to Heather Marcus.
Thank you for that introduction. Thank you everyone for joining us. It's a pleasure to be able to talk to you about this topic this evening. Before we get started, actually, I can advance the slides. Excellent, thank you. Just want to provide the disclaimer and then we can get into the meat of the presentation. Just to let everyone know, Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. And also wanted to let you know that Heather Marcus, that's me, and Dr. Mark Boomer are employees of Vapotherm, and Dr. Mike Jacobs is a paid consultant of Vapotherm. So I'd like to start us off with an overview of Vapotherm Access Remote Patient Monitoring Solution, and then we will go over to Dr. Jacobs to talk a little bit about the clinical evidence, and then we'll progress to discuss the practical settings and use in both an urban setting and a rural setting. So I think we're all pretty well aware of the prevalence and the burden of COPD and the challenges with treating patients with COPD. Several of those include the fact that patients often don't recognize their symptoms that are worsening, can indicate an oncoming exacerbation because they're symptomatic every day. It's tough to know if today is worse than a typical day. And even when patients do recognize that their symptoms are starting to trend in the worst direction, there can be an inadequate or delayed response time on the part of the health system. And that was probably even prior to COVID, and now that's maybe even more challenging due to resource strain and staffing. And then finally, there's just so can often be challenges in resources to overcome the friction in the system. So for all those reasons, back in 2004, Dr. Jerry Kreiner and the Temple Lung Center staff decided that they wanted to find a better way to treat patients. And the keys there would be something that was easily accessible to patients, would identify worsening symptoms and allow for a timely intervention so that patients' symptoms could be treated in a very efficient way and to prevent worsening that would reduce the likelihood of them being admitted or going to the emergency room to be treated for their symptoms. So they applied for and received a $4.8 million grant from the Commonwealth of Pennsylvania, and the studies that Dr. Jacobs is going to actually walk us through here in a minute resulted in a lot of great findings and ultimately formed the basis of what is now Vapotherm Access. Key components here, and I'm going to walk us through, are the fact that patients who have COPD have symptoms again every day, but they're all different. So there isn't really a well-established threshold like there is for maybe hypertension or another condition where the same numbers would be out of range for every patient. So what was really important in this Vapotherm Access was to have a unique fingerprint or baseline for patients with COPD to understand what that particular patient's typical state of COPD would look like. And that was really a key to identifying symptoms that would be a new onset or a change in that patient's condition. And so going forward, what Vapotherm Access then does is connects patients so that they can daily do their report for their symptoms. So it's a combination of patient-reported symptoms as well as connected devices like pulse oximetry and a peak expiratory flow vital recording. And again, a key here to make this accessible and effective for as many patients with COPD as possible is making this available through a combination of smartphone technology, computers, tablets, and also being able to do this with a live person over the phone to make this very accessible. Once those symptoms are collected, a proprietary algorithm helps to monitor those changes from that unique fingerprint, right, to detect anything that could be either within an expected range or if it's outside the range of what's expected for that patient. Then we move to the next phase here, which is alert. In addition to being an application and a proprietary algorithm, there are nurse triage services to provide support to manage and figure out what's next for that patient, to make sure that that patient can navigate the system effectively and efficiently. And the nurse does the work to ultimately involve, as appropriate, the physician to do the sign-off and the ultimate intervention. And again, this is a very proactive process. The important thing is to get timely care, to be an extension of the care plan and the care team already in place at a physician's office, and it's making sure that the patients get the right care at the right time. So key to doing this is making sure that patients are proactive participants and doing their symptom logging every day. Obviously, that means it has to be very simple, so it can't take a lot of time, and it needs to be something that every patient can do. So patients typically spend less than 2 minutes a day logging their symptoms with Vapotherm Access. It's daily respiratory symptoms. Again, there is a connected device, but it's also things like sputum quantity and consistency and color, things that it's really important for a physician to know in order to decide whether medications need to be adjusted. Again, if these symptoms differ from the patient's baseline, both the triage team is alerted, and as you can see in these colorful pictures, the patient is getting feedback that their symptoms are in or outside of range and telling them what's going to happen next. Okay. In addition to having this acute workflow that alerts patients and nurses that their symptoms have started to exceed their baseline range and be something different than usual, there's also a history that evolves in that patient's symptoms over time. And you can see this is, for example, just what one patient's symptom change looks like over time. Again, there's a symptom change score that's provided. It's basically the sum of symptoms that have deviated from that patient's baseline. So the higher these numbers, the more that patient has worsened. And the colorful dots on the chart represent the clinical intervention that was taken by that patient's care team, assisted by the nurse, but signed off by the provider. So there's a combination of rescue medications. This is just great patient education. You know, I'm sure you wouldn't be surprised how many times it just helps to have the nurses remind how they can escalate and use the rescue medication, or even just remind them to have taken their maintenance medications, and that can often result in symptoms returning to baseline. In other circumstances, they've already tried those, and the symptoms haven't resolved to baseline, so you can see the other colorful dots where a steroid may have been added or prednisone taper, and in the case of purulent sputum, antibiotics could be added. And you can see over time, a patient, whether or not this patient's symptoms are well controlled, whether their exacerbations are becoming more frequent or less frequent, whether they're well managed on their maintenance medication. So in addition to having a nice acute workflow, there's a real discussion that can be assisted for long-term management with the patient and the provider. Again, to be able to provide support to patients, it's got to be something that is very efficient and effective, right, in terms of providing scale. So in addition to having this application with an algorithm, there is a contact center that staffs health coordinators who are non-clinical, but just patient navigators, helping patients with either technical support or just questions they may have about who to call. And there's also nurses doing the triage. So just to give you an example of how this is important, if we were collecting a lot of symptoms and it was too sensitive and everyone was alerting, it would be really difficult to manage that number of patients. But that's not the case with this algorithm. It's not only sensitive enough to detect worsening for patients, but it's also identifies just the ones that need the most amount of attention. So, for example, this is one real physician that is managing, in this case, 755 patients. The first thing to take note, high patient engagement. 83% of patients have done their symptom log as expected, which is very common for us, although not very common in the remote patient monitoring world. So in this case, you have 626 patients that have logged in, but not all of those require attention of a nurse or provider. So if you look here in the colorful part of the graph, 12% or less, only a small subset of the patients that are doing their check-in fall in the queue requiring nurse triage attention on any given day. Most of those, in this case, the 80 number on this graph where it says mild, are really mostly getting standing orders patient education on their rescue medications. And that small subset of about, in this case, 13 patients are having a change in their treatment plan, likely a medication order being signed off by the provider. The other part of this is, making sure that this is very timely. So it's both efficient and effective, and to be effective, it has to be pretty quick. So the time to treatment here on average for this group of patients was 3.5 hours. The important thing here is, standard of care is not always being able to intervene for the patient on the same day, and that's what we're able to do with Vapotherm Access. It's mostly on the same day that they receive feedback as to what the next step that they should take, whether it's to take existing medications or pick up something else. So based on the great work that was done by Dr. Kreiner, Vapotherm Access has evolved to basically two key products or two key use cases for the patient. One is, not surprisingly, a post-care use of this. And the focus here is to reduce readmissions, right? So patients coming out from the hospital that have been discharged for a respiratory-related condition can be managed and monitored using both the platform and the nurse triage services to ensure that they're following their discharge instructions and getting additional touch points with that care team to try to reduce the likelihood they'll come back to the emergency department or be readmitted. And then on the other side of that is the Vapotherm Access 365. So for patients who are at risk or have a significant respiratory condition like COPD, who are at risk of admission and need to be managed every day of the year, this is a long-term monitoring solution that, again, the goal here is to be proactive to manage symptoms and prevent patients from going to the emergency room or the hospital in the first place. So that just gives you a nice overview of Vapotherm Access. I'm going to turn it over now to Dr. Jacobs, who's going to walk us through some of the clinical evidence in the early study to validate this.
Okay, thank you very much, Heather, for that excellent overview. We started, Dr. Kreiner started with the idea of a randomized controlled trial in order to get to the point where you're seeing the Vapotherm Access system. That trial was the PA SCOPE trial. It was a Pennsylvania study of COPD exacerbations. It is a parallel group, randomized but unblinded trial, and included COPD patients between the ages of 40 and 60 years. They could have been current or former smokers, and in order to enrich the population for a potential hospitalization, we required that patients have a hospitalization within the past year. Why did we want to do the study? We'll touch on the rationale now. This is, and Heather already went over this to some extent, but it bears repeating. One is that it's true that the early recognition and treatment of COPD exacerbations really does lead to reduced hospitalizations, reduced emergency room visits. But oftentimes, patients don't recognize how their symptoms change from their usual state of health. Day-to-day variations are really difficult to pick up. And as we all know, that COPD patients have symptoms every day. So it becomes difficult to say, well, it's actually worse today than it was yesterday. Then the other problem that we tried to address in the trial is that if people do say, hey, this is a bad day for me, then what do? Well, what we would like them to do is, call in and inform their provider that they are having symptoms. They may need some intervention, but they oftentimes don't call in. So what Dr. Kreiner developed was this telemedicine platform that would facilitate the early detection and treatment of these COPD exacerbations. On the left-hand side, you can see the symptoms that are reported. I'm not going to go over each of those, but we do have major symptoms and what we would call more minor symptoms down at the bottom. Patients were randomized into two groups, and both groups reported their symptoms every day. They were given a smartphone and access to the app. Symptoms were brought up, they went through, and as Heather pointed out, they could report these symptoms in about 2 minutes after a little bit of a run-in period. Everybody reported their symptoms. The difference between the two groups, the intervention group, is that their reports, their initial reports were used as a baseline, or what we like to call it is an anchor. The reason for that is that you can raise an anchor, and one of the things that we noted is that once people get on a streak where they have a lot of good days in a row, their overall symptom burden tends to decrease, and so we kind of raise the anchor a little bit so that they don't have to fall back to the really the worst state that they're in. The scores were then analyzed through that proprietary algorithm, and if they exceeded a point, and again, this was the magic of the system, that ultimately what happened is the patient that were in the intervention group were informed, that they alerted, and that they were instructed to call the call center. Those who were in the control group just reported symptoms. Their reports were not reviewed. They weren't analyzed. They were not informed that their symptoms were getting worse. But they were instructed to call their provider if they felt that their symptoms were worse. Individuals who didn't contact the call center ultimately received a phone call from the call center, and after a while, things kind of morphed into the alerts would be made, and the call center would just make the call. And so patients got to rely on that. So we didn't have so many people calling in saying, hey, my symptoms are worse now. This is a consort diagram of the PA scope trial. I won't spend a lot of time with this, except to point out that we attempted to enroll 400 patients. We had 4 centers for this, and it was difficult to get people to want to participate, largely because the consent form asked them to enroll in a trial that we anticipated would take 2 years. And individuals very quickly said, no, I don't think I want to participate in a 2-year trial. So we've gotten smarter since then, and for some of our patients, some of our current trials, we ask people, you say, we need a year's worth of data, and just to go from there. And if they want to continue in a trial, we give them that option, but we don't try to get them in for 2 years right up front anymore. Ultimately, we had a relatively small group that completed, about 35 people in each group, and you can see the reasons for dropouts. The original goal, as I mentioned, was to show a reduction in hospitalizations. We didn't achieve enough power in order to get to that goal. Fortunately, we were able to get a lot of data in terms of the kinds of symptoms that patients reported for exacerbations. And basically what you can see is that the intervention group tended to report largely mild symptoms, and fewer had moderate or severe symptoms compared to the control group. The next thing that we wanted to do is to show that we were actually achieving the goal for an early intervention. And for this, we developed a quality improvement program. We identified 30 patients who had been using the COPD co-pilot telemedicine program. That's what it was called at the time. They were followed for a median of 185 days. and resulted in over 5,000 patient days of observation. During that time, there were 24 patients generated an alert, and the mean reporting compliance for this was about 86%. One of the things that, when it comes to reporting these, some patients are, almost fanatical with this. We had some patients who were hospitalized, and in the hospital continued to report their symptoms, even though we couldn't treat them because they were all being treated in the hospital. But they get programmed to want to be able to do this, and they keep following up with that. These are the kinds of symptoms that were reported, and as you would expect, dyspnea is the most frequently reported symptom across the COPD patient population. Also, the presence of sputum and cough. And you can see fever, sore throat, relatively small numbers of those reports. But as we all know, patients with COPD have symptoms every day. They experience some level of dyspnea every day. The importance of this is that what we're measuring is an increase in the degree of dyspnea and an increase in the presence of sputum production. So again, it's based against their baseline or anchor symptoms, and the algorithm is picking up on differences from their baseline. Here's where we have the time to treatment in hours. And for individuals who are using this, we ask them to please report your symptoms by noon every day. What happens? You'll see that there's a little tail to that. It takes a while, up to 25 hours for some to get to 100% response. The good news is everybody gets responded to. The question is, why does it take so long for some of these responses to occur? And it's largely due to the fact that patients like this, they have a hard time getting up in the morning. And, in following up with them, I said, gee whiz, you missed your reporting by noon. They said, I don't get up till 1 o'clock. I don't get going until 1 o'clock. But for those who are up early, you can see that the average response time is under 6 hours, and we get 90% of the responses in around 11 hours. So that's the good news. Now, that sounds, pretty amazing, and it is. And in comparison, I've included this comprehensive care management program that was done at a VA study. This is the big study from the VA. They did a smaller study initially. They had one nurse who was extremely committed to managing her patients. And based on the good results that she had, they came up with a multi-center study. In the multi-center study, they got a little less cooperation. Follow-up wasn't quite as good, and ultimately, this study was stopped early because patients that were in the comprehensive care management program had an excess number of deaths. There were 10 in the CCMP group versus 3 in the control group. It's unclear why that actually happened. It may have been that people who got the comprehensive care management program may have felt that they were better able to manage their symptoms, or they better understood their symptoms, and maybe they delayed getting treatment. They really weren't sure. But one thing that we are sure of is that the time that it did take to initiate treatment after the initiation or the start of the exacerbation onset. And in their own report, they showed that the intervention group, it took about 6 days to start steroids, took 7 days to start antibiotics, which didn't differ at all from the control group. So it's kind of clear that, if you're not going to have that early intervention, you may have some worse outcomes. And now we're going to look at things in the urban setting. And Heather, I'll just invite you back for a second. You want to go over the safety net in Philly?
Yeah, thanks, Mike. I really appreciate it. Thanks for walking us through that seminal study. It set the foundation for what's going to come next year. So just to give everyone a sense, we're going to walk through now some of the practical applications in an urban setting to start, and some of the outcomes that have been achieved there. But to give you a sense of the context as Dr. Jacobs walks us through what's been accomplished, we're talking about a setting that it is a customer here is a safety net provider in Philadelphia. So it's a full-service safety net hospital located in Philadelphia. In case you're not aware, Philadelphia is the largest city in the United States that does not have a public hospital. It's located in a federally designated medically underserved area. So just to give you a couple more points just to consider, 83% of this population in a provider service area is African American, Latino, or other minority. And 85% of patients are covered by government programs, specifically over 50% are Medicaid. So it's a very challenging population for a lot of reasons, so keep that in mind when Dr. Jacobs walks us through what's been accomplished. And just to give you a sense of how it's being used in this setting, Vapotherm Access is being used in a lot of different ways. Their goal was to include access for COPD patients wherever they are in that ecosystem. So the health system is using it in a variety of different ways. So, for example, the post-care services are being utilized in the post-discharge setting, so patients being discharged to have a respiratory-related admission or going home with a box with the devices in it and getting started. They're also using the Vapotherm Access 365 service in a couple different ways. The lung center, the pulmonologists there are managing their own patients. The primary care network is also managing their own patients, so you can see that has applicability in both the more mild patients being managed by, and it can also be complicated, patients being managed at the PCP level and also the pulmonology level. And then finally, there's a unique aspect here where transplant patients, lung transplant patients specifically, both pre-lung transplant and post-lung transplant are being managed either prior to the procedure to just make sure that they're stable, or post-procedure for up to a year to manage their symptoms. So it's kind of a unique aspect. They're using all of the services. To just keep in mind as Dr. Jacobs walks us through, each provider is signing off on their patients, not just kind of at the referral level in the case of the post-care services, or when all the patients are being referred kind of at the start of the onset from one of the 365 services. They're also doing sign-offs in their EHR for the patients that need an adjustment to their care plan. There are over 700 patients in the combination of these services currently being managed today, and there's been historically more than that, because the post-discharge patients can often end after they're being managed in their post-discharge period. And also just wanted to say that during the COVID surge and early in 2020, this particular health system also used a modified Vapotherm Access solution to manage their over 20,000 of their employees for COVID symptoms and screening upon the building. So they're using this in a lot of different ways. All right, thanks. I'm going to kick it back to Dr. Jacobs to kind of discuss the different things that we were able to accomplish in the setting.
Okay, thanks for that again, Heather. One of the things that, as you can see, is that this is a challenging patient population, as Heather pointed out, and these are some of the results that we have from the Medicaid Medicare plan member pilot report. This is the initial use of this, and this was not randomized, was not controlled. Patients essentially served as their own control. So we looked back pre-enrollment, inpatient claims for the prior year, and then time to enrollment, and followed that patient out for a year. And those two time periods were compared records that were reviewed from April 2014 to March 2018. And in this case, we had over 50,000 member days pre-enrollment, over 45,000 post-enrollment, and COPD exacerbations were identified by those ICD-9 and 10 codes listed below. Some notable things. Again, I can't overemphasize that this is a very challenging patient population. Yet we continue to see overall 80% daily engagement, which, to translate that, it's the number of potential reports that could be made versus the number that were actually made. So we had total daily symptom reports of over 35,000. Of those, we can see about 19% had symptom change. Most of those, 15.6%, were mild symptom changes. And again, the beauty of this system, as I see it, is that identifying those mild symptom changes and getting to that patient early allows us to make interventions that are less complicated, get people back up to their baseline, and move them forward. A relatively small percentage, just about 3%, have moderate or significant symptom changes. There were over 6,000 remote responses by a nurse and physician during this time, 60 per member, and you can see 91% of patients received a response, and 100% of these were made in the same day. So I'm going to send a shout out to some of the patients for getting in their symptom reports early enough so that we can get them all tuned up the same day. These are the symptom changes that are reported. And you'll notice that during month 1, there's a lot of symptom changes that are reported. They are divided into acute and subacute. Subacute patients or symptom reports only require intensification of bronchodilators. Those with acute symptoms typically need antibiotics, corticosteroids, or both. And you'll notice that within a month, things start to level off. There are always going to be patients. They're always going to have symptoms. It's just a matter of degree and following up. And so you can see that they start to stabilize, and then over that 6-month period, we have fairly consistent lowering of overall symptoms. This, to me, is one of the more amazing things. If you take a look at all-cause inpatient emergency department utilization rates, inpatient-wise, there was a 41% reduction in utilization, 21% in the emergency room. If we break that out into COPD interventions versus non-COPD interventions, and we notice again that there's 46% reduction in inpatient utilization and almost 20% for acute exacerbations of COPD. But we have also a reduction in other types of hospital utilization, both inpatient and emergency department. As we are all aware, patients with COPD have many comorbidities, among them diabetes, cardiovascular disease, particularly congestive heart failure. And we're able to facilitate a reduction or in even non-COPD hospital utilizations, just because they're able to report, their symptoms and get back to their provider. individuals were asked just some simple questions, but it nonetheless important. Has the co-pilot program helped you to avoid or reduce your need to go to the emergency room or urgent care center? 91% said yes. So they recognize this, and although we didn't measure, have a quality of life survey here, my guess is that people who are not going to the emergency room or to the urgent care center are having a little better quality of life. And that's what, they report that as well, 85%. And you feel better able to understand your COPD and manage your symptoms. 98% agree that that is the case. And so now I'm going to turn it over to Dr. Boomer, who can address the issue of practical applications in the rural settings. Dr. Boomer?
Yes, sir. Appreciate the great data and insight from the urban setting. Now we switch to a more rural environment. Oklahoma has a great blend of both urban and rural settings with a tremendous diversity of patients, including multiple Native American tribes, as well as an economic environment that's across the spectrum. But as you will see, there's approximately 250,000 patients with COPD in Oklahoma. It had the fourth highest per capita incidence of smoking in the United States, behind 3 tobacco row states. And you can also see that it's tremendously underserved, as there are essentially 41 pulmonary specialists across the state. Now, this number fluctuates a little bit, and some of these people are spending most of their time in the intensive care unit, so these numbers may not be precise, but they indicate how underserved our population is. You see the geography of Oklahoma. You also see the population density to the left. And you will notice that not only is there diversity in every other way, but there's also diversity in the population density. And about the time that Vapotherm was going to incorporate remote patient monitoring, we decided that access to care for our patients was a tremendous problem. And you can see that access to care is a tremendous problem, not only because we're underserved by pulmonologists, but also because we have a significant portion of the population that's rural and a significant distance from care in miles. Our goal was to provide same-day access to pulmonologists and respiratory providers. We felt like because of the underserved nature of our population that we were not meeting our patients at their moment of need, and started open access, pulmonologist-driven respiratory urgent care center, as well as a clinic. We basically created a hybrid model, and to this point has been tremendously successful and is showing great growth patterns. We have a walk-in pulmonary clinic in addition to scheduled pulmonary clinic, in addition to urgent care. Our goal was to intervene early, same day, and prevent trips to the emergency department or hospitalizations. We added Vapotherm access to scale by managing patients in the home and incorporated both remote patient monitoring as well as telemedicine. Self-insured businesses and populations can also incorporate into this process, and we are actively negotiating with insurance companies as well as self-insured corporations. And we also have public and private insurers that include Medicare, Medicaid, and multiple Native American tribes. To increase clinical capacity, this walk-in clinic has partnered with other providers via Vapotherm access telemedicine capabilities. This has extended our reach and hopefully will help us in regards to the lack of providers. We believe that remote patient monitoring, as well as open access walk-in clinic with same-day access, as well as telemedicine, are all important pieces of their overall strategy to give same-day access. And we tend to continue to increase this process by expanding our RespirCare network, as well as our remote patient monitoring capabilities, as well as our telemedicine capabilities. We are partnering with a network of providers to support in-person visits statewide. We have instituted programs with hospitals, and one would think that hospitals would consider themselves competition, but in fact, by reducing readmissions and reducing lengths of stay, we have found that they're eager to partner with us to see those people within 7 days of discharge and hit some of their quality metrics in a better way. We also believe that this will help in the long-term chronic care management and reduce readmissions. So this gives you a comprehensive look at how we expect these walk-in pulmonary clinics to be a key member of the community, with referrals from hospitals, referrals from businesses, walk-in referrals, and public and private insurers participating in the process. This is a survey of patients under service in 2021. Better understand and manage their condition. The result was 83%. Improved quality of life, 74%. Reduced ER and urgent care visits, which I think is the most important number in this slide, 70%. You can see that our numbers are slightly less than the numbers presented in the urban setting, in both understanding as well as improved quality of life. And part of that has to do with continued difficulties, in my opinion, with access. Thank you.
Thank you, both Dr. Boomer and Dr. Jacobs, for walking us through the practical setting. It's great to see access helping so many patients. I'd like to open it up at this time for some questions. Anybody is able to submit your questions there on the chat. I see some coming through, so feel free to keep submitting those. We have plenty of time for some questions. I'll go ahead and we'll take the first one, and open it up to all of us to answer. There's a question here in the chat about whether or not there's any of the panelists have seen increased willingness or adoption from patients for telehealth or telemed since the pandemic. Dr. Boomer, do you want to answer that one from your perspective first?
Would be happy to. We've seen a significant increase in willingness, presumably from patients that are traditionally reluctant for remote patient monitoring or telemedicine, and that would be the elderly. With the pandemic, we've seen a significant increase in willingness, especially in rural environments, to initiate telemedicine. And we believe that this program is an absolute godsend to rural healthcare.
Thank you so much. Dr. Jacobs, anything to add to that you've seen in some maybe the more urban settings that you've been talking about?
Yeah, I believe that everybody's getting a little bit more used to doing telemedicine. And so some of the hesitancy actually comes from physicians. They still like to see patients as part of the reason why they went into medicine in the first place. But for practical reasons and for safety reasons, we've necessarily had to shift over to telemedicine. And this particular system is, relatively fast and simple to use. So I think people just incorporate it into their lives, and so I know I'm trying to answer a different question, but at the same time, it's the ease of use. We had individuals during the clinical trial that said, "I don't think I can do this," and there were a couple individuals that had some difficulty with the smartphone technology. I think that would be less of a problem now, but overall, it's very adaptable.
Especially if there may be some support technologically from a contact center, right? I would think that would help.
Yep.
Great. I'm going to look here to see if there's any more other questions coming in. Very interesting. Do we intend to do traffic controls?
Well, the one I'm reading it just says, is it only available for COPD patients? And I know that Dr. Kreiner was working with one for patients with asthma and one for patients with idiopathic pulmonary fibrosis. But I'm not sure that has made that out in the clinical use.
So it's a great point, Dr. Jacobs. There are a lot of things that can be done with this, and I think currently today the labeling is mostly for the patients studied. The patients studied in what we've been talking about today have mostly been diagnosed with COPD. But again, I don't know, Dr. Boomer, if you put any other, patients, because providers can refer patients at their discretion that they think would benefit from this. I don't know if you've used this in other patient populations.
We believe that this will eventually extend across the spectrum of pulmonary diseases. I think one of the important ways that we've utilized this is with COVID and monitoring symptoms and monitoring for symptoms with COVID.
Yes, thank you. There is a different application that I was alluding to a little bit earlier for the COPD. A lot of the symptoms had similar questions, right? And so there is a variation for COVID screening that's being used for the both patients and an employee basis to identify potential COVID symptoms. I'm just moving along here in the questions. Do we mind discussing the future of Vapotherm access and remote patient monitoring? I think part of that was a little bit in what you were talking about at the end there, Dr. Boomer. Do you want to talk about that first, and then I can add possibly?
We believe that the future of Vapotherm access and remote patient monitoring will extend to multiple pulmonary diseases. We believe that this is going to be a significant improvement and help transition to the respiratory medical home and value-added propositions with insurance companies, and that this simplicity, as well as the fact that these people have access to not only computer-driven data, but also the human interaction, makes it significantly advantageous in regards to same-day access, as opposed to the data collection with devices that have no human interaction to intervene.
Thank you, Dr. Boomer. I would add, to the extent that it's about improving access, right? We talked about urban setting and rural setting, and I think we've talked about access to care, and that could mean a lot of different things. So the addition of the telehealth, the expansion to the COVID have been a couple trends in that area, and I think there could be a lot that could be done in the future to expand access for patients to care that's needed. We talked about comorbidities, for example, and other socioeconomic challenges that are barriers to receiving care. So I think those would be right, areas for expanding and improving. Great questions. Please keep them coming. We definitely have some more time here. I see a few more. Very interesting. So do you intend to do traffic controls in the earlier stage of COPD AE? I think that means the traffic controls, the color coding, like the stoplight. Is that what's meant there? Dr. Boomer, do you have some thoughts on that?
Well, I think it's pretty straightforward that early intervention in acute exacerbation prevents admissions and ER visits down the line, and I suspect that's what the traffic controls are, like a red, yellow, green light type of process, which would be fairly straightforward to do, and I think there may be a role for that.
Dr. Jacobs, do you want to discuss how the mild, moderate, and significant colors were arrived at? Was that inspired by the traffic controls? It looks similar.
Yeah, it is similar. I'm a little bit more intrigued by the earlier stage of COPD, acute exacerbations, and one of the things that it brought to mind is, we're participants in the COPD gene study, and there we enrolled patients that were not only had COPD, but they were also at risk for COPD. In other words, most of them were just smokers. Well, what we found is that some of these individuals who actually didn't have significant airflow impairment still had a lot of COPD symptoms. And that, to me, is, that's like the earlier stage. And I guess the question is, if you're in that group, they still have exacerbations, even though they have relatively normal airflow most of the time. Some of these patients would have up to 6-7 exacerbations a year. So, one, it's a good reason to stop smoking, but at the same time, it begs the question of, is there a way that we can institute this in patients that are maybe a little less sick than what we typically see in the pulmonary clinic?
Dr. Jacobs, I see two questions that are related, so I'm going to put them together if you don't mind. One is this program covered by any payers, especially commercial payers? And the other is, can a pulmonologist, ostensibly, or a PCP, a provider, bill for Vapotherm access services? So we'll take them together. On a fee-for-service basis, can they be billed? The answer is potentially yes. So there are reimbursement codes that are available for qualifying patients. So those would be the remote patient monitoring codes, and Vapotherm Access does provide a reimbursement guide to assist with that. Ultimately, the billing decisions must be made by the provider, and there are certain qualifications that need to be met, but those are available, and the remote patient monitoring for Vapotherm Access does fall into those categories of available reimbursement codes. But I think the more general question about is it covered by any payer, so that would be the remote patient monitoring codes are on a fee-for-service basis. Obviously, there's CMS reimbursement there, and there are commercial payers that are following those codes. And I think, as Dr. Boomer was alluding to in some of his work specifically, and then in others we're seeing as well, in the terms of at-risk, the movement towards at-risk care or value-based care. So some payers are looking to engage and provide Vapotherm Access specifically to drive down costs and improve patient care. So that's why those metrics of quality of life, improving quality of life, are so important, and the reduced utilization that you saw in that that Dr. Jacobs was discussing for that urban setting outcome were so important. So there's a couple different ways on a fee-for-service basis and also in terms of value-based care.
Heather, I will also add that CMS has mandated in 2021 that payers have to reimburse for those remote patient monitoring codes. And so I think their options in regards to opting out of paying for them are limited in 2021.
And Heather, I see that there's one other question that popped up that probably something I should have covered in a little more detail. It says, are you planning to include the new parameters such as peak flow? And when I presented, I kind of said, well, the symptoms reported are on the left-hand side, and peak flow is part of this. And what we ask the patients to do is to do a peak flow maneuver 3 times. We ask that the numbers come in within 20% of each other, and I think the current system actually measures that, and then report the best of the 3 attempts. Interestingly, this was an issue that we weren't exactly sure we're going to need because peak flows work well for asthma. It's not clear that they work as well for COPD, but we do have some patients who actually alert because of peak flows. The other thing, and I know we're running short on time, is just to mention that the trend is gently upward, not significantly so, but over time, patients' peak flows tend to improve slightly, largely because they don't get knocked down, with continually worsening symptoms.
Mm-hmm. Yes, thank you. I'm going to move on to that question next. Thank you, Dr. Jacobs, for including that. And that is correct, the evolution there. It is a significant contributor to the symptom change. And I think it was, I'm not sure if it was on the slides that were presented, but in that same study for the practical application in the urban setting, I think that there were we could go back to the slide. I think that there were a number of patients that at 6 months had an improvement in their peak flow. I think it was over half the patients that had that as well. So thank you for pointing that out. I think that we are coming up at the end of our time together. Time has been flying. It's been great to have everyone. Is there any final questions before I could turn it back over to our wonderful hosts to wrap up this evening? I would just thank my co-panelists, Dr. Boomer and Dr. Jacobs, for joining me this evening, and thank you so much to ATS for having us.
Thank you.
Thank you, Heather.
Thank you all for joining.
Thank you.
Thank you, speakers, and thank you to everyone for attending today's webinar, Efficient, Intelligent, and Personalized Remote Patient Monitoring for COPD, How to Ensure that Your Patients Get the Right Care at the Right Time. If you have any other questions, please contact Heather Marcus at heather.marcus@vtherm.com. If authorized by the sponsor, the webinar will be posted to the ATS YouTube channel in about 2 weeks. On behalf of Vapotherm Access and our presenters, thank you for joining us today and have a great rest of your day.